When we talk about antepartum testing and screening options, we need to know that historically, really few methods of assessment were available to provide information about the growth and development of the fetus. Today, we really have improved accuracy and detection methods that give expectant parents and their care providers a better understanding of the nature of the pregnancy and the condition of the baby. The options available often give information in the form of either a screening tool for a particular risk factor or a definitive confirmation of a potential problem. Of course, advantages, disadvantages, and limitations exist in using these tests. Proper education of the patient is crucial for determining both the appropriate use of the test and the risks involved to both the mom and her baby. One of the most commonly used antepartum fetal assessment tools is the ultrasound. This tool uses sound waves, usually high frequency, to determine specific tissues and surrounding structures. The more echolucent or reflective a tissue is, for example, like bone, the more defined the structure on the monitor. In OB, both abdominal and transvaginal ultrasounds are commonly used. It may be used to take snapshots of the fetus, or it can even show real-time movement of the baby, the blood flow through the heart of the baby or through the umbilical cord, and even the surrounding maternal structures such as the uterus, the cervix, and the amniotic sac. Widely available, it may give 2, 3, or even 4-dimensional pictures, each providing increasing detail depending on the type of ultrasound machine used. Several levels of ultrasounds are used, each for specific rationales. The basic or standard ultrasound is commonly used as a general survey of the pregnancy. This is the most common level, frequently performed as a sort of first look at the developing fetus and its environment. The earlier in the pregnancy it is performed, the more accurate it is in determining gestational age, as the next few slides will show. The second type of scan is called the comprehensive or specialized ultrasound. It looks for a specific abnormality that might have been noted on the standard scan. Also known as a level 2 ultrasound, it is usually referred to a more specialized OBGYN known as a maternal fetal medicine specialist who is trained in the higher risk aspects of pregnancy and fetal development. The third type of ultrasound is the limited scan. This is often done in labor and delivery units to confirm vertex or breech presentation prior to initiating a plan of care. Alpha-fetoprotein, or AFP, is the most abundant protein found in the fetal circulation. Produced by the embryonic yolk sac, the GI tract, and the fetal liver, it is excreted into the amniotic sac through the fetal urine. Crossing the placenta, it enters into the maternal circulation where it can be measured in her serum. Abnormal levels can indicate serious problems with the pregnancy, but it is a screening tool, not a definitive determinant of a healthy pregnancy. When the placenta is formed, tiny microscopic projections from the outer membrane of the chorion, known as chorionic villi, develop and burrow into the mom's endometrial tissue. Now, these villi are actually fetal tissues that reflect the chromosomal, metabolic, and genetic makeup of the fetus. This is usually done rather early in the pregnancy to diagnose these types of disorders. Pregnancy loss after a CVS procedure is about 1 in 100 procedures performed. This is a similar risk to the amniocentesis, which we'll talk about next. However, the major advantage of using CVS is that it may be done earlier in the pregnancy, most commonly in the first trimester. This gives the parents earlier access to diagnostic information. Risks of slightly increased limb reduction defects, however, have been linked to CVS. Amniocentesis is a procedure best performed via ultrasound guidance around 15 to 20 weeks of pregnancy, which is also called the mid-trimester. Here, adequate fluid volume and viable fetal cells are more abundant in the amniotic fluid. It is most commonly done at this time to evaluate the presence of chromosomal abnormalities in a fetus, but it may be done for additional reasons listed here. When performed in the third trimester, amniocentesis is used to determine fetal lung maturity or fetal hemolytic disease, often caused by maternal Rh incompatibility. Current literature suggests, however, that fetal lung maturity does not ensure that respiratory distress will not occur in the neonate, but that it demonstrates a lower risk of respiratory distress at birth. Percutaneous umbilical blood sampling, or PUBS, is an invasive procedure used to either prenatally diagnose a fetal condition or delivery of therapy to the fetus. Diseases typically associated with Rh disorders, such as an abnormal blood clotting factor, Rh disease, or fetal acid-base balance, are the most common reasons for utilizing PUBS. As the procedure uses a needle to directly puncture the umbilical cord, it comes with higher risk for significantly poor outcomes. This requires significant counseling of the parents. In performing antepartum fetal surveillance, one has three goals. One, to determine fetal health or compromise as accurately as you can. Two, to reduce perinatal morbidity and mortality. And three, to guide the intervention by the obstetric team in determining a plan of care. The most common methods of performing fetal surveillance are the following: the non-stress test, or NST, the contraction stress test, or CST, the biophysical profile, or BPP, and the maternal assessment of fetal movement, also known as fetal kick counts. We will discuss each of these. This slide shows two different electronic fetal monitor tracings labeled A and B on the left lower side of each tracing. The dark vertical lines indicate 1 minute of time. The lighter vertical lines indicate 10 seconds. The top blue graphic on both strip A and strip B indicate the fetal heart rate. This is in beats per minute from 30 to 240. The bottom, smaller blue graphic in both A and B tracings indicates the uterine activity from 0 to 100 millimeters of mercury. The hand labeling FM onto the paper indicates where the nurse wrote in fetal movement. In each strip, a baseline or resting heart rate of each fetus can be determined. In strip A, it is about 125 to 130. In strip B, the baseline is about 145. In strip A, we see several episodes of accelerations of the heart rate in response to fetal movement, with rises in the beats per minute to 140 and 160. To determine a reactive non-stress test, we must see two rises in the fetal heart rate of at least 15 beats per minute lasting for at least 15 seconds. Each of the two elevations of fetal heart rate must be within a minimum of 20 minutes of time. In tracing A, if 20 minutes of monitoring occurs, this would be called and interpreted as a reactive tracing. Strip B, at this point, with about 10 minutes of tracing showing, would be considered non-reactive and would warrant some form of nursing or obstetrical intervention. Non-stress test, or NST, is used to determine fetal heart rate accelerations in response to fetal movement. It is a non-invasive test using both the electronic fetal monitor that measures the fetal heart rate by ultrasound and uterine activity with a tocodynamometer. By observing rises or accelerations in the fetal heart rate, we can interpret basic information about fetal oxygenation in utero. Normally, as the fetus moves, the heart rate elevates. This indicates a healthy fetal central nervous system as demonstrated by the ability of the fetal heart rate to respond to stimuli. The test has specific parameters to determine test results. These are called either reactive or non-reactive findings. Sometimes the time that we select to do the non-stress test corresponds with a time when the baby's asleep. Ways that the nurse can waken the baby are either by giving the mom something to drink and eat, or she can use a vibroacoustic stimulator. This is just a small device used to transmit sound to the baby, hopefully to wake the baby up and move and then therefore elevate its heart rate. But the vibroacoustic stimulation can really only be done after 33 weeks when the fetus's hearing has developed. Contraction stress test is exactly what its name implies. We give the mom contractions in the uterus, which is a form of stress on the fetus, and determine if the heart rate of the fetus changes in a way that would tell us that the fetus is possibly not being well perfused. It is done often when the non-stress test findings are either non-reactive or inconclusive. This slide demonstrates two fetal heart tracings during a contraction stress test, or CST. Tracing A and tracing B each show a pattern of contractions demonstrated by the hill-like formations on the lower components of the strip. Tracing A demonstrates a lack of decelerations or dropping of the fetal heart rate below the baseline of 135 beats per minute. It is categorized as a negative CST. Tracing B, however, demonstrates decreases below the 120 beat per minute baseline. This type of description of the decelerations will be determined later in class, but please recognize that these decelerations are described as late in timing, meaning that they occur after the contraction has peaked. This type of deceleration is often associated with placental insufficiency and can be labeled a positive CST. A way to remember this outcome is to consider if the baby shows repetitive decelerations with contractions, then it is positively stressed, thus a positive CST. A biophysical profile, or BPP, is a non-invasive test that uses an ultrasound to observe four areas of fetal well-being: fetal breathing movements, gross or large fetal movements, muscle tone, or how well flexed the baby's limbs appear, and amniotic fluid volume. Each of these areas are given a grading of 0, 1, or 2 for a total score of 8. It sometimes may be coupled with a non-stress test on the same day of the ultrasound. The biophysical profile can give an excellent picture of presence and severity of fetal hypoxia or worsening acidemia, as the next slide will demonstrate. Maternal assessment of fetal movement, also known as fetal kick counts, are another non-invasive way to determine fetal well-being. Fetal movement correlates well to reassuring fetal condition, as we discussed earlier in NST testing. Daily evaluation of fetal movements can help in determining fetal well-being. Difficulties in performing fetal kick counts, however, can be noted in variations in the normal fetal activity, such as sleep cycles, maternal activity, obesity, and medication use. Atypical changes in fetal activity is well documented as a valid form of fetal surveillance. It is best done after the mother eats or drinks at least 8 to 10 ounces of fluid, then lies on her side. She is taught to concentrate on the movements using her hands on her abdomen. She should be free of distractions such as the TV or phone and should note at least 10 movements in 1 hour. If less than 10 movements are noted, she should continue for an additional hour and should report the outcome to her provider.